Good morning to all. I am Reggie Mole from Global College of Nursing. Today we discuss about poliomyelitis disease. Poliomyelitis disease is caused by poliomyelitis virus. First we see about general characteristics of poliomyelitis virus. This is an RNA virus belonging to the family Picornaviridae. It is the smallest of RNA viruses, measuring about 21 to 30 nanometer in diameter. The virus is naked and expresses isosacral symmetry. There are three serotypes: serotype 1, serotype 2 and serotype 3. Each serotype is capable of causing poliomyelitis independently, and there is no cross protection. Pathogenicity of poliomyelitis virus. Poliomyelitis is transmitted from person to person by contaminated drinking water. Infected person sheds the virus in feces, which contaminates water. The disease is more common during monsoon season. The virus primarily multiplies in the intestine, is carried to bloodstream and thereafter to the nervous system. The clinical course of the disease follows in a few stages. Stage 1, subclinical infection. During epidemics, the ratio of clinical to subclinical infection is about 1:100. The virus is ingested, multiplies in the intestine, and the individual is apparently normal and asymptomatic. Such asymptomatic subclinical infections induce substantial immunity to the individual and serve the same purpose as vaccination. Stage 2, abortive poliomyelitis. The virus multiplies in the intestine as well as in the tonsils and adenoids and reaches bloodstream. The person suffers from a short fever with sore throat, which subsides on its own after 5 to 7 days, thus providing immunity. Stage 3, aseptic meningitis. From the blood, the virus reaches the central nervous system and affects meninges. The patient becomes drowsy, has vomiting and neck rigidity and other signs of meningitis. Stage 4, paralytic poliomyelitis. From the central nervous system, the virus travels along the axons to the peripheral nerves. The presentation varies, but usually flaccid paralysis manifests in 1, 2 or 4 limbs. Complete recovery occurs in 80 to 90% of cases. In 10 to 20% of cases, residual paralysis remains for life. The affected limb undergoes disuse, atrophy and does not grow to normal size as the other limbs. Next, laboratory diagnosis. First, virus isolation and identification. Throughout the course of the illness and until after a few months of convalescence, the virus is excreted in stool. Stool sample, therefore, is ideal for virus isolation and identification, since the virus is likely to be confused with many other enteroviruses which may be present in stool. Immune electron microscopy is done to confirm poliomyelitis. The virus can be grown in tissue culture, monkey kidney cell lines or the Freifort cell lines. Next, serology. Complement fixation test can be done. A 4-fold increase in titer of antibody is significant. Initial titers should be estimated during acute phase and subsequent titers during convalescence or after 15 days after the first test. Next, prophylaxis. 2 types of vaccines are available. First one, killed or chalk, and live attenuated or Sabin vaccine. Both of them have advantages and disadvantages. Selection of vaccine should be based on the immune status of the child. Next, pulse polio immunization. All the children in the country are immunized on the same day to avoid epidemics of poliomyelitis. Next, therapy. No antiviral drugs are available against poliomyelitis. Treatment is mainly directed to reduce the residual damage that might be caused and to mobilize the child as far as possible. Physiotherapy has a major role to play in managing residual paralysis. Okay, thank you.